see, so that I will be able to see those of you who are on camera. It's helpful to me to see at least some people and see how people are reacting or responding. It just helps me so that I'm not just talking to a camera. Now let's see here. I need to share my screen. Share screen. PowerPoint. Share. All right, now I've got to rearrange things. All right, I can still see some people here. Let's see. All right. Okay, so you can all see the PowerPoint. Is that correct? Yes, great. Thank you very much. So you can see a few names there of people who've been involved in at our office at the Contra Costa Crisis Center. And if any of you all are interested in more information, a primary name that you can connect with there is Caitlin Coffrin, our volunteer and training manager. You can see her email address there. Again, you all will be getting the PowerPoint, I guess, in a few days or whenever. Let me go on. Oops, that didn't change the slide. Let's see here. What's going on? Where's my arrow? Let's see if this works. All right, here we are. So here in Contra Costa, we answer, and this is a little bit unique throughout California and throughout the nation, we answer the 211 info and referral line, and then we are longstanding a crisis center. We are coming up on 60 years of being a crisis center, and that is answering crisis lines. So I'm going to show us a few more slides, but a way to reach us in Contra Costa is if you are in Contra Costa, you and your phone in Contra Costa, you dial 211, your call should come to us. We have a long-standing 800 number, 800-833-2900. We also have texting, text the word HOPE to 20121. And then we are a part, you'll see it on another slide, we are a part of what used to be called the National Suicide Prevention Lifeline, what is now called the 988 Suicide and Crisis Lifeline. That's the national 988 number. All you do is dial 988 from anywhere in the nation, and the call will be routed based on your phone number to a local center. So in fact, throughout the Bay Area here, there are several centers, and the call will come based on the phone number, or will be sent based on the phone number to the center that the computer thinks is nearest to that phone number. And then if that center is not able to answer it, it'll roll to another center. So calls roll around throughout here in the Bay Area. Anyway, that's the 988 line for the Suicide and Crisis Lifeline. So here at the Contra Costa Crisis Center, we do answer those national crisis calls, the national suicide calls. We answer local calls on our local numbers, all about crisis and suicide. We also answer the 211 info and referral line. I'll show us a little bit about that. That's helpful information. It's not absolutely directly related to suicide prevention in itself, but it's very helpful and related, especially for referrals and resources, for needs, for people in crisis, but also for everyone in the community in general. And then we also, at our crisis center, we have grief counseling. That has long been a part of what we do, grief support groups. I want to highlight one particular grief group. We have different groups, different populations that might be served, but a very important population that relates to what we do as a crisis center is that we and other crisis centers might also have this. We have a support group for those who are survivors after suicide loss. That is, the people who remain alive after someone else has died by suicide. And so there are unique aspects to those who are grieving a suicide death. So we do have that. And if any of you all or anyone you know or anyone you meet is indeed a survivor of suicide loss, that is, someone else has died by suicide, then they can give us a call and participate in the grief support that we have. Our hotlines are 24 hours a day, free and confidential. Everything that we do for people in need is free of charge. Let me go to the next slide. Let's see if this will work. All right. So what I'm going to do, brief overview of our services. I've just done that. I'm going to add to that with a few of the slides coming up. In this first part, we're going to do very basic suicide prevention. You know, we are here this morning for an hour and a half. That is not enough time to go through all of this to do. Sometimes I could spend at least an hour and a half on suicide prevention alone, but we're also going to get to risk assessment and intervention, and that's part 2. So we're going to be rushing through here. I'll pause every so often to catch my breath, see if there's some questions to break it up here so that I'm not doing absolutely all of the talking. So over that brief suicide prevention, of course, it's a difficult topic. I'll say more about that in a moment. How to help someone, asking directly about suicide, safety planning, protective factors, and then part 2, risk assessment and intervention. So again, the variety of calls that we answer here at the Contra Costa Crisis Center. The 211 info and referral line, again, all you have to do is dial 211. I did notice in the chat when you all were introducing yourselves that some of you are from other parts of the Bay Area. I even saw other parts of California. The 211 line throughout California, more or less, is operated county by county. Again, it's based on where you and your phone are located. So if you are in Oakland and you dial 211 from your phone in Oakland, your call will go to the Oakland, the Alameda County 211 service. Now, if you do get the wrong service, we can transfer you from one to another. That's about social services, health services, assistance for those in need, practical assistance. I'm going to show you a list of the kinds of things that are in a 211 database. Then, of course, we answer the 988 national line, suicide related. Either the individual who has thoughts of suicide can call in anytime, 24 hours a day, or if someone is concerned about someone else, let's say like a student at school is concerned about a fellow student, a classmate, a friend, and they wonder how to be helpful, they can call us also. A parent is concerned about their child, a spouse or partner is concerned about the other. They can call us. They don't have to have thoughts of suicide. They're concerned about someone else, or you are concerned about someone else. Give us a call. We'll coach you through it. Then also the third major bullet point there for crisis and grief. Now, maybe you noticed the new name of the 988 line is Suicide and Crisis Lifeline, which means you don't have to have thoughts of suicide to call the line. It's for people who are in crisis or people who are grieving a death. So it doesn't have to be related to suicide. Someone's stressed. Now, it can also be about oneself or about someone else. It can be mental health related. Certainly, various people know people have others in their lives, and they're struggling in some way related to their mental health. And maybe the caller is interested, someone can call us and talk about what it could be some resources for the one about whom they are concerned. So again, that's the variety of calls that we answer at the Contra Costa Crisis Center. Next slide here. Here is, it's very small print. I'm going to quickly read through all of this. The kinds of resources that are in a 211 database. COVID-19 updates, rental payment assistance, eviction prevention assistance, PG&E payment assistance, PSPS preparedness. That's when PG&E shuts down the electricity to try to avoid wildfires throughout our state. So PSPS stands for Public Safety Power Shutoff. Homeless services, low-cost housing home referrals. Now, let me pause right here. Whenever we talk about the homeless services, low-cost housing, maybe many of these services, there is never enough. We do know what's out there, and we here in Contra Costa are part of what's called coordinated entry services for those who are homeless. So we're a good place to start, and maybe that's the case in other 211 counties also. All right, let me go on. Food pantries, meals, mental health services, mobile crisis response team, particularly for people in mental health crisis, physical health clinics, dental care, substance use services, Kick It California to help people avoid to kick smoking. Financial assistance, limited, but there are agencies and churches and groups that like to help out as much as they can. Free tax preparation, that'll be coming up early next year. Low-cost, high-speed internet for those that qualify, legal services, education, job training, parenting support, senior services, disability assistance, veteran services, LGBTQ support, domestic violence, sexual assault, rape. So certainly the Family Justice Center and all of their services qualify in various of these categories, and they are certainly listed in the 211 database. And if someone were to call 211, we give out those phone numbers and other phone numbers for this tremendous variety of services. Let me move on. Throughout California, all the 211 services, all of that information in the database is available to anyone, anytime, worldwide. So for us in Contra Costa, it's 211cc.org. If you go there either on your desktop or your phone, you'll see this more or less. You'll see these different icons. There is also a search bar. I want to just highlight, because today's presentation is about suicide prevention. You'll see that top icon, the ribbon for suicide prevention. It's teal and purple. If you were to click on that, I'm going to show you what you would see. You'd see the next page there, or that next block, and then you see a few other icons where you can click on those and then get more specific services that could be helpful related to suicide prevention. We also have additional trainings in case you want to send other people or in the community. We have them every month. We have a 1-hour suicide prevention by Zoom in the evenings, and then quarterly. So early next year, we'll launch in with a 2-hour training. See, normally it's 2 hours. Here, I got to rush through in an hour and a half. I do see someone is waiting to be admitted, so I'll just click that there. All right, so at any rate, go to our website for more information. We do have promotional materials. We've got wallet cards with our phone numbers. That big blue, mostly blue, is a window cling that you can stick on a window or a fridge or whatever. All right, give us a call for that. We do need volunteers. We do need staff. We are hiring. You know, with the new 988 number, we have an increase in calls. That's great. That's wonderful. And we're hiring. So I don't want to steal from any of your agencies, but look us up. All right, let me just pause, catch my breath. Anything that I can clarify, Karina? Any questions related to these services?
I do see a question that said, is 988 different from the Access and Crisis line?
Is 988 different than the mental health access line? So the mental health access line in Contra Costa County, they're also a 24-hour line. There, I believe, I may not be their best representative, but I believe that what they are about is getting people into the county mental health system. So assessing and referring, and that could be for anyone, I believe, including uninsured and certainly those that have Medi-Cal. The 988 line is a first stop, and it's also providing support over the phone. Now, maybe the mental health access line in Contra Costa County does that, although I believe that their primary purpose is to provide support and direct people directly to the clinics. How's that for an answer? Anything else?
That was the only question so far. I do see a comment added that said, that's correct. The MH access line can schedule those within Contra Costa Health Services and also externally when appropriate.
All right, wonderful. Well, let's launch into very basic, brief suicide prevention. So first of all, you see this little warning sign here. I want to comment, obviously, this is a difficult topic. And maybe some of us who are in this webinar right now, that maybe the topic of suicide has touched our lives in some way, that maybe we ourselves have had thoughts of suicide at some point. Maybe some among us have attempted suicide. Maybe we know people who have died by suicide or who have attempted or have had thoughts. This can be challenging. Maybe we know people with mental health concerns and perhaps some that are ongoing. I just want to say that I want to recognize that it's a difficult topic, and maybe even during this time, our time together, or afterward, maybe it will affect us. And I just want to recognize that, name that, affirm that, and encourage us, whether during this time, obviously you can step away. Some people may be stepping away, I realize that, but I want to say that it is important to take care of ourselves and maybe even reach out to the numbers or to other people in our lives who are helpful. I just want to name that, recognize that, and I hope that we can all be, as to whatever degree that we're interacting amongst ourselves, but to be as encouraging and compassionate and helpful to one another throughout our time. So again, a reminder that people can call the 988 line, or there is the previous and still existing longstanding national number, the 1-800-273-8255. That's the national number. It should work. Either of those should work from any phone anywhere in the United States. Then also texting the word HOPE to 20121. That's our local texting. We've long had a grief hotline. We are directing people to call us here at 211 and then the national line there. All right, talking about suicide, that it is so helpful, we believe, overall, to talk about it, to ask about it, but we want to talk about it in a way that is helpful, encouraging, supportive, and reduces stigma. So we have some ideas that we have heard and learned over the years just about use of language. I just want to suggest this to us. I know it's not easy to change that overnight, but just for the sake of this. So often we hear the common phrase of that someone has committed suicide. We want to suggest that we avoid that phrasing of commit suicide, because so often, whenever there is the verb commit followed by a direct object, it is something that is usually, most often, negative. And so commit a crime, commit adultery, commit larceny, commit perjury. There are so many commits followed by a noun, direct object, and it's negative. Commit a sin. Now, I'm not here to encourage suicide at all. I just want to help us to move in a direction so that it's easier to talk about. So we just say that someone died by suicide, or believe it or not, suicide can even be a verb unto itself. I don't use it that way personally, but it can be used that way. Now, another phrase, so often we hear, let's say in the news, that someone who has attempted suicide and died by suicide, that sometimes people use the language that it was a successful suicide attempt. Oh, and I just wince that, yes, the attempt ended in death. In that regard, it might be considered like a successful attempt that it ended in death, but it's not a success, it's a death. Now, so I just want to suggest to us to avoid that phrasing if at all possible. So we avoid that. Someone died by suicide. That would be just a way to avoid that. Or the attempt ended in death, or that it was a completed suicide. Just anything to avoid that word success in the context of suicide, except for reducing suicides. That is a success. All right. Other phrasing, suicide loss survivor. I already referred to that. That is that those who remain alive after someone else has died by suicide. They are survivors of suicide loss. Then also suicide attempt survivor. And that is someone who has attempted suicide and remains alive. That's great. There are many people who have attempted suicide and are still alive. That's great. That's wonderful. That's fantastic. All right. Let's take a very quick look at statistics. Overall, in the past 20 years, what I'm presenting are national official numbers, which I'm sure underrepresent what is the actuality, because it's not always easy to figure out if a death was by suicide or not, or some people take great effort to try to hide the fact that it was a suicide because of their sense of shame or stigma for themselves or for the sake of the one who is now deceased. So at any rate, these numbers, I'm sure, underrepresent what is the reality. But over the past 20 years, overall, the number of suicides, official designated suicides in the United States has been increasing. So in 2017, it was at 47,000. That already was an increase. Went up in 2018 to 48,000. What's interesting is then there was a little bit of a dip, and actually overall numbers of suicides have been going down in the United States in the past few years, including during the pandemic, if the statistics are correct. Now, we don't have numbers yet, official numbers from 2021, but it is amazing to me that in 2020, the number went down even when that was the onset of the pandemic. Now, how could that be? Now, obviously, some people were dying by COVID, a number of people, tragically, unfortunately. And then we were aware of the tremendous depression and isolation and the struggle and the stresses of the pandemic. And we've heard about people who were thinking about suicide, maybe even maybe attempted. I personally think, my own personal theory, for whatever it's worth, is that maybe it's exactly the increased awareness of mental health concerns, especially during the pandemic, helped to prevent suicides overall. But even as we look at that, the number of youth suicides actually increased during the pandemic. So overall, the number went down, but the number of youth, young people defined as 15 to 24, went up slightly in the year of the onset of the pandemic in 2020. That's unfortunate. A possible explanation is that the young people were affected to even a greater degree than other people, and everyone was affected. All right, so another point there, if you can see in the first half, looking at the percentage of male versus female death in terms of the gender binary, 79% of the suicides in 2020 were males. So far and away, more males are dying by suicide than females. 21% of the suicides were female deaths by suicide. Looking at the youth statistics in 2020, the number of youth defined as 15 to 24, 6,000, just over 6,000 youth deaths by suicide. Overall, in 2020, suicide was the 12th leading cause of death. It actually ticked downward because of COVID. COVID outpaced and pushed downward, or it was new to the list, but suicide. Among youth, suicide became actually, even while the overall number went up, it became the third leading cause. I'll tell you the top three causes of death for young people are: number one, accidents. And then number two, switch off over the years. And they're very close. And that is, it's either suicide or homicide. More often, in fact, for the overall population, more people die by suicide than by homicide. And then for young people, it's a trade-off. But what's amazing is, to me, is that we hear about in the news, we certainly hear a lot about suicide. We hear a lot about homicides, and we hear about homicide rates, and we hear about cities where the rates are up or down, or what's the number one city in the nation for homicides. We hear those kinds of things. And yet more people die by suicide than by homicide. More people kill themselves than are killed by other people. Let's keep going here. Suicide attempts. Now, this is based on research in general. It's hard to exactly get a hold of this number, but it is believed that for every death by suicide, there are 25 attempts. Now, that doesn't mean that every individual attempts 25 times. It just means that in the overall population, for what we know to be the number of attempts, that there are a lot of attempts out there. And many of the people who attempt do not die. Now, that's great. That's wonderful. And yet, all it takes potentially is one attempt that could possibly end in death. Now, if we look at youth, now this is a very far-ranging statistic, and it may not be helpful except to a certain degree. And that is that for every 100 to 200 attempts, one of those among youth, one of those 100 to 200 will end in death. Now, on one hand, that's good news, that there are a lot of those attempts, and most of them, the vast majority of them, do not end in death. On the other hand, that's a lot of reported attempts. That's a lot of what they're calling attempts. Now, if they're still alive and we know that they've attempted, they can get help so that they don't attempt again, so that there can be less distress in their lives. If we can just identify these people, which actually, I was just talking to someone last night, a young person, a high school student, and she was talking about attempting suicide a year ago. And I actually asked her, did you ever talk to anyone about that? And she said, no, she has never. That last night was what she said to me on the phone last night, was the first time that she has ever said to anyone else that she had attempted suicide. I believe it is so valuable, so important that people get help, that they go to their doctor, they go somewhere. Anyway, senior adults, for every 4 attempts, one of those will end in death. So that means if you are working with senior adults and they're talking about suicide, and if they're making any movement toward attempting suicide, there's a higher likelihood that any attempt that they make will end in death. We just want to be aware. Now, that doesn't mean we don't care about the youth and we say, No, we all still care, but just realize if we're dealing with senior adults, higher likelihood that any attempt will end in death. Once again, looking at gender, gender identity, it's presented, these are stats from the CDC. They're following the, what we might say, the gender binary, male, female, masculine, feminine. Again, the second bullet point there, males 3 times more likely to die by suicide. We already saw that. Females are 3 times more likely to attempt. So women are attempting more often, but dying less. Men are attempting less, but dying more proportionally. Well, I mean, both the hard number and their attempts. So when a man attempts, it's more likely that the man will die. When the woman attempts, less likely, but we still want to help. We're going to take a look at this, I think, a little bit more. Suicide loss survivors. There's one stat that for every death by suicide, 6 people will be affected in a significant way. And then a wider stat is that 135 people will be exposed. When there is a suicide death in a community, in a known community, let's say in a small town or at a high school, that many people will be affected, even if they don't know the individual who died by suicide, but they know that someone among them did die by suicide, it can affect someone. So let's say, I like to say at a high school, let's say that a senior were to die by suicide. There could be some new freshman who doesn't even know the senior, isn't a senior, obviously, but hears about it. The hearing about the death, learning about the suicide death could affect anyone at that school, that freshman, let's say, who doesn't even know the senior, that maybe that person is already struggling to some degree. And then this plants the seed that suicide is in the realm of the possible. And so that's why there are what we call postvention, when the grief folks will be there, the school counselors or our people, others to be there to help provide support in the moment following a suicide death or a homicide or any tragic death, and to identify folks who are particularly affected and to try to get a sense of, does someone else have thoughts of suicide, and get help for them. All right. In Contra Costa, in general, the number of suicides in Contra Costa hover in the 90s and the low 100s, just FYI. Looking at our calls to our call center here in Contra Costa in 2021-22, the most recent fiscal year. These are just our stats. I'll have to say they're very imprecise. It all depends on all of us answering the phones and then checking off boxes on our call records. But what do we see here? That suicide issues, 3,800 of our calls out of our 15,000 calls, the topic of suicide came up. But look at this. We're going to look at how we determine our rating of low, moderate, high. And that's a subjective to some degree determination. But look at this, that the vast majority of the calls we rate at low risk. That's encouraging. And it shows us that it's great to talk about the topic and that we can help keep people safe, that you can have thoughts of suicide and stay alive, and struggle with that and get help, but stay alive. And then moderate risk, we rated 375 calls, high risk, 72 calls, initiating a rescue, where we would call 911 or maybe the local mental health crisis response team. We've only done that 81 times. Now, actually, I'm looking here at the number. The number is a little bit higher, you may wonder, than our high risk, because sometimes we can do that for people in a mental health crisis, maybe having a psychotic episode, who are not suicidal, actually. So that's why that number might be higher. But I can tell you this, we don't even do it that often, 81. That's not even 2 times a week on average. So we can help to keep people safe without that level of intervention, of sending them to the psych ER. Now, some people want to go. In fact, when we do it, the vast majority of the time, the people want to go. We're not working against them. It is very rare when we make a decision for their safety that is contrary to what they think they want in the moment. Of course, it's our job to help to keep them safe and alive. But what's amazing is most of the time when the people who call us, they want that help. Safety plan, we're going to take a look at that we created that on various calls. And then all the rest of those calls, third-party callers. I love third-party calls when they're concerned about someone else seeking info on suicide, or maybe they've told us that they've had thoughts of suicide or even attempted suicide in the past, but they don't have thoughts of suicide now. All right, let's keep going here. Top methods for death by suicide. Throughout the United States overall, firearms far and away, 53% of total suicides are death using firearms. Second place, 27% suffocating, hanging. Third, poisoning. That would be overdosing or carbon monoxide, for example. Falling from a bridge, from a building, 2.3%. Cutting, piercing. Let's round up to 2%. And then, of course, there's also drowning occasionally, lower on the list. I want to comment on cutting, piercing. You know, certainly self-cutting is a behavior that is increasing among our population and among young and youngish people. And yet look at this, that only 2% of the suicide deaths are known to be from self-cutting. Now, we get lots of reports when we're talking to folks on the phone about their self-cutting behavior. It's good that they talk about it. Then the next thing is to ask about thoughts of suicide. So often, their cutting is not about thoughts of suicide. Nonetheless, it's still a risky behavior. The cutting can make it easier to attempt suicide when they might have thoughts of suicide. And the self-cutting behavior in and of itself is still dangerous and risky. All you have to do, obviously, is cut deeper than you intended, and it can be very dangerous. And so at any rate, though, it's interesting to know that many people who engage in self-cutting do not have thoughts of suicide, at least when they're talking to us, but we want to check in on that. All right, myths. Let me quickly go through this. A lot of people have had the idea that asking or talking about suicide will give someone the idea to do it, that it will plant the seed. We say no, to the contrary. To ask about suicide is good and helpful to give someone the opportunity to talk about what's going on. Now, the challenge is keeping them safe. When people call us on the crisis line and our protocols, so often we can help to keep people safe and then send them on their way. And that's that. And they can call us again, or maybe they'll pursue other support for themselves. But to talk about it is great. Next bullet point. People who attempt suicide want to die. There's nothing you can do about it. I remember when I first saw this a decade ago, I thought, oh, it's a trick question. Well, of course they want to die. It's in the word. They're attempting suicide. They wanted to die. But no, it's not really that people want to die. That's not their first goal used most of the time. It's that they want the pain to end. So if we can help people with that pain, if we could eliminate the pain, that'd be great. If we could reduce the pain, that's nice. But also, if we can support them and accompany them in their pain so that they are not alone in their pain, so that they might not feel alone in their pain, that can help a lot. Next bullet point. Males have the highest rate of suicidal behavior. You already know the answer to this. It's kind of a trick sentence there. Women have a higher rate of suicidal behavior because they're attempting more, but more men die by suicide. Next bullet point. You should ignore people who threaten or attempt suicide for attention. I hope that sounds ridiculous, but really, people sometimes do that because obviously some people make remarks, joking or otherwise, about thoughts of suicide. Sometimes someone may, let's say a kid in a family, and the parents are saying, no, you can't go to the party. And the kid says, well, then there's no point to my life. I'm going to kill myself. And the kids and the parents think to themselves, oh, they're being manipulative or dramatic. Well, I say, yes, it's hard. There's no doubt about it. But I want to say this. We need to be like the TSA at the airport. When you're going through the line at the TSA at the airport, you don't get to joke about having a bomb or a knife or that you're thinking about hijacking the plane. They have signs that say, don't joke about it. Because if you do joke about it, they're going to pull you aside and they'll talk to you for hours on end, make sure that you really are joking, and you'll miss your flight. So also, if anyone makes any indication or thoughts of suicide, our task is to respond. And even if they say, no, I'm just kidding, of course, they may not be. But we say, well, look, we're here for you. And of course, or there's this number that's here for you. It's real. Many people are dying by suicide. So we want to take these remarks seriously. Final bullet point here. Suicide usually occurs without warning. Again, someone somewhere somehow came up with it. 80% of the time, there is some indication that someone has had thoughts of suicide. Now, that's supposed to be an encouragement to us that if we can know the signs and know how to respond, then we can help to keep people alive. Yes, that's true. I do want to be sensitive to anyone among us or anyone who has lost someone to suicide. Inevitably, probably the majority, if not most, of the people who have lost someone to suicide and are feeling that loss, grieving that loss, probably are questioning themselves, blaming themselves. I should have known, I should have seen, I should have said, I should have done. What went wrong? And then I come along here and say, oh, well, most of the time there are signs and indications. I'm not here to add any burden. And in fact, to the contrary, that's why I say it's supposed to be encouraging that if we know what to look for, know how to respond, it's not always easy. I mean, here we are spending an hour and a half together, which isn't even enough. But to realize that even when people are identified as having needs, that regrettably, sadly, sometimes they're even connected to services, to health, to mental health. Sometimes it's not enough. And in fact, truth is, it's a terrible statistic, even after people have gone to the psychiatric emergency room for thoughts of suicide or attempting suicide, and they go and they spend a little time and eventually they're discharged, that it's an alarming statistic, too high, that a number of those people within the year do actually die by suicide, which is why it is so important to follow up, to make sure people are connected to ongoing support. And in fact, our agency is now collaborating with our own local psychiatric emergency room, that they will identify the people, encourage those people to call us, and we will provide ongoing follow-up. Anyway, let me go on here. Let's take a look at, very quick, steps of suicide prevention. This is a three-panel wallet card that we have developed. And if any of you would like this, it's two-sided. One, this side, obviously English, the other side, Spanish. I'll joke and say you just can't see it. It's on the other side of the PowerPoint. But we do have these cards available. If you want to write to us, we can send you some. We can also send you a PDF and you can print them off for yourself. We had to figure out what steps to put on here. I don't know how many of you are familiar with different programs related to suicide prevention. Sometimes there are 3 steps of suicide prevention, sometimes 4, depending on how you want to count it here. We've done 5 or 6. We've done the look and listen for the signs, indications that possibly someone has thoughts of suicide. Ask directly about suicide. We're going to be looking at each of these steps in the upcoming slides. It is the general recommendation that it is good and great and wonderful and helpful to ask directly about thoughts of suicide. Express care, reach out, follow up. We're going to look at each of those. We have some of these bullet points. Well, let's just start in. Let me go to the next slide here. Look, there are so many things to be looking out for. We limited it just to, not have minuscule writing on the wallet card. But basically, it's keep your eye out for anything. So even here, topping our list, not because it's so top, but hopelessness. Now, I want to say, everyone feels hopeless to one degree or another at one point or another for a longer time or a shorter time. The question is, do they have thoughts of suicide? So in fact, that's why it's good. It's an invitation to us to ask about thoughts of suicide. If someone who is withdrawing from loved ones in a significant way, that's an invitation to ask about thoughts of suicide. Changes in mood or behavior that are significant. It can be an invitation to us to ask about thoughts of suicide. Now, here's one that is more indicative. It's a higher risk. If someone is giving away prized belongings in a premature way, prematurely preparing for death, that can be an indication that they are thinking about suicide. And then there are many other signs, but we're going to move on. Listen, people drop hints. People make ambiguous remarks. That is that we don't know how to make sense of what they're saying. That's why some people say, if someone says, well, I just can't go on. Like someone says, oh, they wonder, does that mean this person have thoughts of suicide? I'm not sure. Some people just say, oh, well, let me just ignore that. I'll pretend I didn't hear it. I want to say it's an invitation to us to ask, well, gee, what do you mean? Or more directly, to ask, gee, does that mean that you might have thoughts of suicide? It will all be over soon. No one would care if I were gone. There are a number of these kinds of sentences that people will say. That's an invitation to us to ask what do they mean and to ask if they have thoughts of suicide. And I want to, and also to empathize with them, to empathize with their loneliness, or to their sense, their feeling of loneliness or feeling of rejection or whatever it is, but also for our purposes to ask directly about thoughts of suicide. I always want to encourage us to try to avoid a debate. And a debate would be, when someone says, no one would care if I were gone, and we say, well, yes, lots of people would care. You're then entering into a debate rather than empathizing with the feelings of loneliness, and also missing the opportunity potentially to ask directly about thoughts of suicide. So here, asking about thoughts of suicide, the national line gives this framework. We don't expect anyone, those of us who answer our calls or you all, to get out, a 3x5 card and ask this question. This is a framework. So what is the benefit? Let's take a look at this. Sometimes when people are experiencing whatever and feeling whatever, they might be having thoughts of suicide. So I want to ask you, are you having thoughts of suicide? Notice here we're asking about thoughts of suicide, and we're differentiating between thoughts of suicide and acting on the thoughts. Now, in the second part, we're going to go further, and we would ask questions. So this, if indeed they're having thoughts of suicide, then we do want to assess further. Are they making any plans? Have they prepared for those plans? Do they intend to? Do they want to attempt? When? How? But here we're just talking about thoughts of suicide. That's it, thoughts. It's good to differentiate. All right. And then to help people to recognize that they can stay safe even with thoughts of suicide, potentially. Anyway, now what's the benefit of this? The first part of this is that if we were to talk to someone and say, gee, I hear you're going through whatever, we then are letting them know that we hear them, we understand, we know what they're going through. And if we reflect that back and empathize, and then we're normalizing it, we're contextualizing it, that obviously lots of people these days are having thoughts of suicide. Lots of the people these days are attempting suicide. Lots of people are dying by suicide. And so therefore to go through all of this and to have thoughts of suicide, I mean, that happens. So in other words, they're not so crazy for having thoughts of suicide. And therefore, I want to ask you, do you have thoughts of suicide? Now, there's a shorter version. Gee, you mentioned you're going through all of this, so I want to ask you, do you have thoughts of suicide? Now, let me give us an example. I wrote this, mindful that I'm speaking for and with the Family Justice Center, the Family Justice Institute, which has a lot of services related to abuse and related to assault. So at any rate, sometimes when people have experienced relationship violence, and maybe they're feeling that they're blamed for the abuse that they're enduring, that they are being blamed even while they're the victim. Sometimes in the midst of all that, and then they've got to separate or protect their kids or whatever else is going on. In all of that, they have thoughts of suicide. So I want to ask you, do you have thoughts of killing yourself? Notice I'm asking about suicide. I ask about killing. I don't ask about hurting. because that may not get us the answer that we are looking for. That hurting, sometimes they think they're actually helping themselves and others by killing themselves. Or hurting also might be the self-cutting or self-injury, and it doesn't exactly get at suicide, attempting to kill themselves. I feel like there's, I don't know, oh, it's on my computer there. All right, a shorter version. Gee, you said that all your problems will be over soon. Are you thinking about killing yourself? So let's take a quick look at what might keep people from talking about their feelings and their thoughts of suicide. This just helps us to be sensitive. We want to be sensitive and somehow address this. Now, this is obviously page 1, we have page 2. So they're uncertain of the reaction, the underreaction or overreaction of the listener. Maybe previous conversations have been ignored or avoided. They feel like they've been indicating or dropping hints left and right, and no one's picking up on them. And so they are shutting down a little bit. Maybe they are embarrassed, of course, to let people know that they have thoughts of suicide. They're uncertain about accepting help from others in general. There are differences in cultural norms regarding from whom to ask help and from whom to accept help. So we just want to be aware of that and be as sensitive as possible. Differing cultural norms regarding what is illness, what is mental illness, what is stress response. Some people have an attitude of, well, just, tough it out. And then we want to be as supportive and helpful as possible as we talk about a difficult topic. Let's go on to the next page. What makes it difficult for people to talk about their thoughts of suicide? Fear of being punished, fear of being hospitalized. Absolutely. And that's why I'm here to say that so often, at least for people who call us, they do not need to be hospitalized, that the needs can be addressed in a less intrusive method. Now, when that is needed, when that's indicated, then we certainly want to use that tool. But that has got to be one of the most significant interventions. And that so often for us, we don't need to use that tool. They don't want to be a burden to others. They fear being treated with a lack of respect. They don't want to appear weak. We just want to be sensitive to all of that. All right, so we are going through these quick, rough and ready steps of suicide prevention. We also, of course, want to express care. I thought this was a very nice addition to the list of steps. And so we're looking and listening, we're asking directly, and we want to express care. I'm here for you. We provide active listening. We express empathy, no judgment, no matter what. Maybe some people have made some decisions that have not been helpful to them or others at all. And in the midst of that have thoughts of suicide. And so we want to be supportive to the individual to help them to stay alive and help them to grow and learn and maybe address whatever needs to be addressed. Stay calm on our part, ideally. Remain patient. Be comfortable with uncertainty. Be comfortable with the pain. We can't fix everything overnight, but if we stay alive, we can slowly but surely address whatever there is to be addressed. And we want to believe in the capacity for change. Reach out. Let's find help. Let's make sure you're safe. We're going to talk a little bit about this in the second half, but this is very basic. Right now, it's basic level suicide prevention. So for the general population, yes, let's make sure you're safe. That one's hard, but one could even ask directly about that. Do you feel safe right now? And see what the person says. Now, part of being safe, safety planning. There's actually 2 apps. We're going to look at this list in 2 slides coming up here. There is a free app that anyone can download called Safety Plan, and then another one that's called My3. And you can see here in one of the panels that the My3 is named after, you see those 3 circles that you can connect some of your contacts, like whom would you wish to call when you're in a moment of crisis? Now, obviously, you could very well have those people on your favorites list and another part of your phone, but this app was developed a few years ago. Anyway, you could do that. You could see the green oval there of Get Help Now. That connects you to the 988 national line, and then the call 911. Certainly, if someone is at imminent risk or already in the process or already just having attempted suicide, well, obviously, then you do need to call 911 or get that person to the hospital immediately. But so many people can be helped, and we can help prevent suicide attempts simply on the phone or by ongoing support. So then here again is the list. People can go in there and type in and answer those questions to figure out how they can do safety planning for themselves. We're going to look at that list now on the next slide. Let's see if it's not changing now. All of a sudden, my PowerPoint isn't moving. There we go. So warning signs. This one's a little bit difficult, but the individual who might have thoughts of suicide, what are warning signs? What's going on in myself? That takes a little bit deeper reflection. If it's too hard, skip it, move on. Next one's easier. Internal coping strategies. What can I do alone so that I feel better? This is good for anyone, anytime, regardless of thoughts of suicide. That is self-care. What can you do alone? And that's different for different people, certainly. And even for the same person, it's different at different times. Number 3 there on the list, social context, interactions. Who can I reach out to, or how can I interact with other people? And that helps me, or it can be a distraction from my distress or from the thoughts of suicide. So maybe they're friends, maybe they're acquaintances. We're not talking about going deep. And maybe even there's no interaction. Some people like to go hang out at Starbucks and just to be in the presence of other people, and that helps. Some people like to go out to the movies or to go to the mall or go hang out at a restaurant, even if they're alone, and that helps them. It's just whatever helps the individual, or to interact directly with other people. Family members or friends. Think about who you either feel or know that you can reach out to and talk in a deeper way, or who do you hope that you can reach out to and talk to in a deeper way? Truth is, it doesn't always go well initially. And then what do? Well, maybe they're professionals or agencies. Now, obviously, you don't have to go in this order, but professionals or agencies that you can reach out to, people that you're connected to in the community, certainly the crisis line, certainly counselors, certainly people at school for the students who are at school, or if people are involved in activities, who are the adults or the leaders that they can reach out to. If they're involved in a spiritual community, a church, a synagogue, a mosque, who can they turn to among there? Who are the professionals? Just whoever can help. Or obviously, Family Justice Center, maybe they can help out. Making the environment safe. And that's about, let me pause here, I see someone admit, we'll admit someone in. Making the environment safe. So if someone has thoughts of suicide and has thought about, gee, I want to use a gun, and they have a gun, let's get that gun locked up or further away or out of the house or given away or sold. Or if there are other means. Now, obviously, in any house, there's going to be something that can be used. But if we get the items further away, then at least then, if someone has the impulse, then it takes a little bit more effort to go get that whatever item and then to use it for that purpose of attempting suicide. But a positive side of making the environment safe, number 7, my reason to live. And that is that to think about in a calmer moment, what are my hopes and dreams? And maybe it's helpful to write it down, because in a crisis moment, people lose sight of their hopes and dreams. They also lose sight of resources that really may be right there. Now, sometimes the resources aren't there and they give us a call and we can help them and direct them to further resources. But sometimes in crisis, people they're not thinking clearly. That's sort of the definition of crisis. And so maybe it's helpful to write it down at a calmer moment and then look at it in a crisis moment. Maybe that can be helpful. All right, protective factors. I love this. And maybe many of you all involved in your different activities, you all can be the protective factors. And so protective factors are what helps the individual, what helps a community, what helps a society. So let's take a look at this list. Available mental health care, medical care, recovery services. If in a given community we've got that, then that helps. Truth is, in some communities, maybe not right here in the Bay Area, but that's a little harder to come by. Or easy access, that still we need more. We need more of that you can easily get to the help. And if you already have established relationships with medical health, mental health, or others, then so that it's very easy to turn to them in a moment of crisis, that's great. And in fact, that's partly so established relationships. Let's say, I mentioned earlier that our agency now has a collaboration with the psychiatric emergency room at the CCRMC, Contra Costa Regional Medical Center, that we hope to be part of that established relationship for that individual who is already at risk, so that they can turn to us. We turn to them, we reach out to them, they reach out to us, we connect them to other services, so that the next time when they're still struggling, it's very easy to get the help and to get that on an ongoing basis. Supportive family relationships, of course that helps. That's great. It doesn't always happen. Sometimes the families are struggling. Obviously, Family Justice Center knows that. So what do you do for the individuals who are suffering? Then we hopefully have supportive connections in the community, or let's try to help build those into the lives of ourselves and the people that we're working with. Let's go on with the list. Support for help seeking. When someone is seeking help as a community, then we are supportive. Sometimes the people around us may have different values. Maybe they make remarks that are not supportive. Obviously, it's not helpful. We want to be as helpful and encouraging as possible. Restricted access to highly lethal means of suicide, obviously, move it further away or get it out of the house, get rid of it altogether. Skills in problem solving, conflict resolution, nonviolent handling of disputes. That helps because it's exactly in those conflicts when people might have violent impulses, violence against others, violence against themselves. So if people can learn how to deal with the conflicts in a helpful way for themselves and for the people involved, obviously it helps. Cultural and religious beliefs that discourage suicide and support self-preservation. That's great. There's also a challenge. The challenge is that when someone is in a given community, a cultural group, a religious group, whatever group that has this value, I agree with the value. Probably all of us agree with the value of life in terms of not attempting suicide. But the challenge is, in any given group, when someone has difficulty either embracing the value or living the value, that they might feel hesitant to approach someone within the community about their struggle. So ideally, even within a given community or value group, that people can be supportive to those who are struggling to embrace or to live the value. Or secondarily, the people might ideally reach out to others who can help them as they struggle with the value. All right, high self-esteem, obviously that helps. All right, following up. Can we talk again? Certainly in the general public can do that. Call, text, message, chat, Zoom, whatever would be if you're with an agency, your protocols. Visit for the people in the public. Certainly we at our agency, we do everything by phone. We don't visit, but we do follow-ups. When we rate someone at moderate or high risk, we'll arrange for a follow-up call. And we'll arrange for that in collaboration with the caller. So how are they feeling? We might call them an hour later, or 2 hours later, or later that night, or the next morning, or the next day, whatever it is. We will collaborate with them in determining what do they feel is most helpful to them. All right, here we are back at the summary. Look, listen, ask directly about suicide, express care, reach out, follow up. I think we've come to the end of, our very basic suicide prevention. I just want to point that, let me see how we're doing on time. Oops, I've got 25 minutes left. Let me just point this out. You all can go to YouTube today, tomorrow, whatever, or when you get the PowerPoint. This is a video. We're not going to watch it together. Teen suicide prevention presented by the Mayo Clinic. It's 10 or 11 years old. It's still valuable. It's still true. It's still right. And it's for more than just teens. And I'll summarize in one sentence what their main point is. Ask about suicide. That's what they tell us. And that's what the Mayo Clinic agrees with. Well, they're promoting, and we agree. All right. So we have come to the end of basic suicide prevention. I'm going to have to rush through risk assessment intervention, but let me catch my breath. Let me see if there are any questions that
there is. While you
out.
catch your breath, Scott, let me go ahead and read them to you, okay? So how about I read them all and then you can kind of answer them.
Okay.
They could be tied together. Do you have tips on how to respond to the chronically suicidal? As well as the question is, does the no one would care a suicidal hint or an emotional manipulation by controlling parent or partner? And then
Ah,
others did
very
also,
good.
yeah.
All right, how about that? I like that question. It's a very good question. And especially in the context of here we are presenting as a part of Family Justice Center and Family Justice Institute, obviously dealing with abuse and violence. And in a relationship or whatever, when someone threatens suicide, okay, yes, you can still take that sentence, that statement seriously. But I believe that you do not, that the spouse, partner, dating partner, or anyone doesn't need to be the individual who saves the other one. Or you don't have to, if you make the decision that you no longer either are in or wish to be in that given relationship, you know, for your, whatever the reasons going on, and the person is then saying, well, you do that, you leave me, or you're leaving me, I will kill myself. You could still be kind and caring, if you wish to be, toward that person and say, look, yes, I care about you. I want you to live. That doesn't mean that it is best for us to remain together. And it doesn't mean that it's best for me to help you with this. Here is a phone number, the 988 number, or the STAND number, or the FJC number, and they can help you. But I cannot be the one to help you with that. But I do care. I do want you to live. And here's a phone number. That's my answer. What was the other question with, help me out again, Karina?
Yes, for sure. It says, give me one moment. Do you have tips on how to respond to the chronically suicidal?
Oh, Lord. That's hard. But I would say this, we get callers, we do get callers who qualify as chronically suicidal. They call us. What they need perhaps is support and to be heard. And obviously they need help and help to stay safe. Now, it is very hard. People want to be heard and believed and understood, and they do want help. So I don't know, that's just my quick answer, is that I know it's not easy. Let's say in a given family, when someone is struggling, and frequently it would be, let's say, a family member who might have an identified mental health illness that is chronic as well itself. That is very hard. But if we can empathize and to work to keep them safe, and when they do say that they're suicidal, let's take a look and go further and then ask some of the questions that we're going to learn in the next 20 minutes to ask and to get a sense of what is their level of risk. Because it's one thing to be chronically suicidal with the thoughts of suicide, and it's another to be at high risk or at imminent high risk for attempting suicide, by definition, sometime very soon.
Okay, thank you. And I think the only last thing that they were putting was that they were having trouble finding the app, that they did find one called Suicide Safe, but they were having troubles finding the app.
I'll have to look further into that. So I don't know what to say. I've got the apps on my phone. I'll have to take a look if, I don't know if they're in the App Store still. Sorry about that. Still valuable. Keep looking, and we'll look into that. Thanks for that input. All right. Let's move on, shall we? So here we are, suicide risk assessment and intervention. I've got 20 minutes, and let's see here, someone admit. All right. So what we're going to do now, well, I'm going to do in 1 minute or less, active listening. We're going to take a look then at suicide risk assessment. There are three main categories and an additional that contribute to, I find this very helpful for how we assess suicide risk, and that is desire, capability, intent. I'm going to define these for us. They're kind of weird words, but we'll get there in a moment. And then we use those categories, and then also another category, buffers, connectedness, those protective factors, that also helps. But the main categories are desire, capability, intent. And then we use those categories to help us think about low, moderate, or high risk, or to assess low, moderate, high risk. Now, there can be some variation, and different people might assess differently based on the information they have or how they feel it or sense it to be the intensity of any of the contributing characteristics or circumstances of the given individual. What is most important is what will be our steps of action. And so, depending on, and really it's if someone's at moderate or high risk, then what do we do? How do we work to keep that person safe? So we're going to take a look at that. Safety planning, we already looked at that briefly. Self-care, practice exercise. We won't get time for that. That's why it's in highlights. Join us again for one of our 2-hour trainings or book us for your agency and we'll come do more. All right, active listening. I want to say this is so valuable. I was just saying for the chronically suicidal, for anyone, it is so valuable to hear them, to hear their pain, to not diminish it, not disagree, not debate, but to hear them. And when people feel heard and understood, they can come to, often, not always, but a calmer place. Open-ended questions, reflecting back, paraphrasing. Let them know, the person that we're interacting with, that we hear what they're going through. Now, here is our crisis model. It's based on a basic crisis model. I mean, whoever knew that there was a crisis model for counseling? This is crisis counseling. It's not long-term counseling at all. In fact, all of this can be done in, sometimes someone can go through the whole thing, believe it or not, in 10 minutes, meaning that not like we're rushing, but that so we engage with someone, build rapport in the call or in the interaction, identify the needs. Why are they calling? Why are they talking to us? Why are we talking to them? What's the issue? And inquiring about their safety related to their relationship, domestic violence or sexual assault, or certainly their safety related to suicide or whatever else is going on. And then assessing what are the resources that are immediately available, that have been available, that could be available, and empowering them and action steps, ideally for them. It's about empowering that person. And in fact, so often when this works, and it's almost like magic, when we are able to hear and help someone, they so often can see steps of action that they themselves want to take. And maybe even they know it and they volunteer. Now we can prompt and we can discuss with them. But also it's wonderful when it happens when they just remember what are their values and what are their hopes and what are their resources or what do they want to do at this moment. But in their moment of crisis, when they first called us, or maybe when they're first talking to you, that they've lost sight of it. And the only way to get to reconnect with that is to allow them the chance to talk about what's going on and allow them to come to a calmer place. Now, again, that doesn't happen with absolutely everyone, but it does happen a lot. Let's look further. Here's more about this validate, appreciate, refer is one of these models. You can see it's by this agency called Active Minds. I just want to highlight this. This is kind of about the active listening. I mean, certainly that's what the validating and appreciating is about. They have a number of videos on YouTube also. They are a great foundation. They serve people in college age and now high school age. They've got great material. I recommend them to us. And I just like this phrase here. You don't need to be an expert to help, although it helps to know something, and it's great that you're here today. But you just need to be there. And for more information, visit Active Minds. All right. 3 prompt questions that we will ask and that you might consider asking. Are you thinking about suicide? Are you thinking about killing yourself? Have you thought about suicide in the last 2 months? Someone somewhere came up with that is an important time frame. Have you thought about suicide? So maybe they're not thinking about it today, but have you thought about it in the last couple of months? Have you ever attempted to kill yourself? Then certainly, if there's a yes answer to any of these questions, then we want to assess them for suicide risk. So let's take a look at what that is. Now, here again is that crisis model with a rerouting. And you can see that's the pink and the red. So you can see they're inquiring, are you thinking about suicide? And then if so, if yes, then assess suicide risk level. You can see there again, we want to listen and assess, and we're looking at the categories of desire, capability, intent, and then also buffers, connectedness, finding hope, and life. And some people have a tendency to want to jump into finding that hope and life. I want to say to us, it is so valuable not to dwell too much, but to give people the opportunity to talk about what hurts, to talk about their pain, because most of the time most people probably don't get the opportunity to do that, or don't feel comfortable doing that, or talking about whatever is their struggle. Now, it's nice if people can do that with their friends or their family, but so often maybe initially they're embarrassed or ashamed or whatever. And so we want to give them that opportunity, and that helps a lot. And then sometimes they remember all on their own what is meaningful to them, their hope and life. So again, assessing low, moderate, high. Maybe someone does not have thoughts of suicide. Obviously, then, at least for now, they are not at risk. But suicidal desire, capability, intent. Here is a spectrum that just to show us, you can see the green to the red, that there's really quite a spectrum. This is very helpful to learn, because what it shows us is that someone, as I've already said, someone can be at low risk. Someone can have thoughts of suicide and still stay safe. And the question is, where are they on this spectrum? So let's take no thoughts of suicide. Maybe there's a passive identification with dying. Maybe there's vague ideation around attempting suicide. We will ask directly, have you thought about a plan? And sometimes people produce this whole laundry list of all the stereotypical ways of attempting suicide. Or on the other hand, maybe someone is very specific and they said, yes, I have a plan. It's a gun and I'm going to shoot myself. So it's one thing if it's very specific, it's another if it's general. Another is, I remember talking to someone, asking him, do you have a plan? He says, yeah, I'm going to jump off the Golden Gate Bridge. Okay, where are you now? I'm in Antioch. Okay, well, we're safe for an hour and a half, at least. So obviously people have these plans. They may be more close to acting on them or less close. Believe it or not, it's a valuable question when someone says, how are you going to attempt? And then they say a gun. I say, and believe it or not, it might sound like a silly question, but well, do you have a gun? No, I don't. Well, then they're safe until they go out and get a gun. So they have thoughts of suicide. They thought about a gun, but they don't have a gun. Now, another part is intention. Like, do they want to? Believe it or not, some people might say, yeah, I thought about suicide. I'm going to kill myself with a gun. I have a gun. They say, but I don't want to. They say that they don't want to actually die. So they're calling, they're interacting with us. They want help. So they have 2 out of the 3 categories. They've got desire, that is thoughts of suicide. They've got the capability, but they don't have the intention for now. So that's only moderate. We're going to get to that. But anyway, so they're safer. They're at some risk. They're at moderate risk. All right. Specific ideation, preparatory actions. If they have rehearsing behavior, then they're getting closer and closer to acting on their thoughts. And then there is the suicide attempt. Often, maybe it does not end in death, but we don't know. We certainly hope it doesn't. And then there could be death by suicide. Let me go on. So again, desire, capability, intent, buffers, connectedness. What we're going to see right here is what goes into the category of desire. Certainly suicidal ideation, thoughts of suicide, that they want to die, they have reason, and it's actually valuable to ask them, gee, what's going on? Why do you think you have these thoughts? What's hard right now? Psychological pain, something has happened, something is of the moment, then certainly that goes into the category of desire. Intense feeling of shame or worthlessness or a breakup or a failure, firing, whatever it might be. Hopelessness, helplessness, perceived burden, feeling trapped, feeling lonely. This is what goes into this category of desire. Now, we have here a list of questions. Now, remember, just a few slides ago, I was saying, well, we want to engage in active listening. And it's so that's more open-ended questions. But then when we get to assessing suicide risk, then we will be asking more direct questions. Now, this is not to interrogate anyone, and the whole thing can be a conversation and a discussion. But we do need to ask direct questions, as I've already hinted. Do you have a plan? Do you have the means? How likely is it? So anyway, here are some direct questions. Again, you don't have to use this language. Make it your own, make it real. So this first question there, the longest one you can see is we've already seen this question. When people are feeling extremely upset, it's not unusual for them to have thoughts of killing themselves. Have you had any thoughts of wanting to kill yourself? What's happening today that has caused you to think about suicide? What are your reasons for wanting to die? Notice all of these are about the death. Guide of possible questions for desire. How do you perceive yourself affecting others? I don't even agree with all of these questions. I don't even use them all. These are, produced at the national level. Use what works for you. You mentioned whatever. Tell me more about how you're feeling. Alone, trapped, hopeless, helpless, feeling like a burden. Say more about that. Capability. So we're just looking at the category of desire. Remember, desire, capability, intent. Now capability, capacity. Do they have the capability now or soon to attempt suicide? So what goes into this? Let me put these up here. We have page 1 and page 2. And again, you're going to get this PowerPoint. Is there a history of suicide attempt of this individual? Well, obviously, if they've tried before, they can potentially try again. On the other hand, if they've tried before and they've gotten help, maybe they're talking to you and they have thoughts of suicide and they know exactly how to keep themselves safe. On the other hand, if they haven't gotten help and if they're still struggling, then a past suicide attempt can attempt that they're at greater risk for attempting again. Do they have the available means? Do they have the means at hand? Have they been exposed to someone else's death and that's affected them? Family member or even someone at school whose name they don't even know, but it's affected them. History of violence toward others. Well, that's an issue unto itself. And also maybe that violence could be turned against him, her, themselves. Recent acts or threats of aggression against others. Current intoxication or substance abuse, certainly. History of substance abuse, recent dramatic mood changes, decreased sleep, increased anxiety, out of touch with reality. In other words, in a difficult mental health moment, certainly that could lead to or be a part of a suicide attempt. Certainly we want to keep the person safe, whether related to the mental health moment or the possibility of attempting suicide. Extreme agitation or rage. Is that everything? Yes. So we've looked at now the two categories, the desire and capability or capacity. And then there's the third main category, intention. We'll get to in a moment. There's a list of possible questions. How are we doing on time? I got 6 minutes. So I'm going to push through this. These are, I don't know, have there been previous times when you wanted to end your life? Long ago. Was there ever a time when you purposefully hurt yourself, even without thoughts of suicide, thoughts of dying? Do you have the means now to take your life? Have you ever been affected by someone else's suicide? Have you ever been violent toward others? I mean, all of these are issues unto themselves and can contribute to suicide risk. Are you drinking or using drugs to cope with your pain? Have you recently been preoccupied with more worries or fears than usual? Let's see here. Do you feel like anger is out of control? How frequently do you use substances? Have you had difficulty sleeping? Anything to eat or drink? Do you hear things or see things that others don't? Would you say your mood has changed a lot lately? Have you had any unsafe or risky behavior that could harm you or others? All right. Desire, capability, intent. Now, intent. What goes into this? Intention is another way to think about it. An attempt in progress. Well, obviously. But plan with a known method. That goes into this category. If it's a specific plan, then that can indicate their level of intention, that they're preparing for death or they're preparing for suicide in an untimely way. And if they've expressed their intention to die or expressed their intention to kill themselves, it's even valuable to ask how likely is it? That's one of the questions. And one of the questions that we are asked to ask our callers, and we're going to see it here, how likely on a scale to 1 to 5. It doesn't tell us everything, but it does give us some indication. All right, so here are some questions. Earlier, you thought about killing yourself. How likely are you to act on your thoughts or your plans today on a scale of 1 to 5? Do it 1 to 10, whatever. Have you made a specific plan to kill yourself? What things have you put in order to prepare for your death? Earlier, you said you were thinking about killing yourself. How likely are you to carry out that plan soon or when. Buffer. Now, this is this add-on category. We've been looking at desire, capability, intent, our three main categories. Now we've got our add-on buffers, connectedness, protective factors. What helps? If this is a part of someone's life already and they can reconnect with it, great. Or if it's not a part, then we want to guide them to what can be helpful to them. So immediate supports, social supports, planning for the future. And that doesn't have to be a big deal, by the way. I was talking to someone, in fact, maybe, I don't know, last night or the night before, talking to someone, and she ended the call. She had thoughts of suicide. She was probably at low risk, maybe moderate, depends on how we want to define it. And that she wanted to be sure to go to bed last night so she could get up this morning and join her sports team for their early morning practice. So that's planning. She's obviously not going to attempt suicide tonight, or doesn't intend to, because she wants to get up and go to her practice, sports practice. Engagement with helping professionals, ambivalence about living and dying. Now, that does not mean indifference, like, I don't care. It's ambivalence is feelings on both sides. And we want to use that people have thoughts of life and thoughts of death at the same time. That's why they're calling or engaging with you. They're still alive. They're still engaged with life, and they have thoughts of death. And that is good. We, of course, want to help them to move to that side of wanting to and staying alive. Sense of purpose, reason for living. Guide of questions. I'm going to skip through that. Now, I got to finish up here quickly. How do we put this together? Low risk. If someone, we would rate someone at low risk if they have thoughts of suicide only. And that's it. They don't have a plan. They don't intend to. They don't want to. And believe it or not, that's a lot of people. So that's low risk. What do? We listen to them, we support, we might do that 6-step safety plan, we might provide resources. So we already looked at the safety plan. I'm going to go through this. Moderate risk, that they have thoughts of suicide. This is what we do at our place. They might have a plan, and they've got 2 out of the 3 categories, but not all 3. That is desire, capability, intent. So they've got desire and capability, but no intention. They don't want to. I already said that example of, let's say they have thoughts of suicide, they have a gun, they might use the gun, but they don't want to. So we're going to help them to live that out, to stay safe. How do we do that? We'll see that in the next step. Or maybe they actually have this, they have thoughts of suicide, they really want to do it, but they don't have the means. Well, we want to help them to stay safe. And maybe they have several supports, life buffers. Certainly, it's always about listening to them, supporting, helping. Listen for feelings of hope, desire toward life. Develop a plan to keep the caller safe in the moment. I mean, especially if they have some means. Let's get that means further away. Let's get that gun out of there. Let's lock it up. What we do is we offer a follow-up call. And we will do it. I already said, whether it's in an hour, 2 hours, later that day, the next day, we'll follow up. Of course, they can always follow up with us, but we will follow up. We will arrange for a follow-up call with them. High risk. Now, there's even a differentiation that they can be high risk when they first place the call or when they first engage with you, but by the end of the engagement, they're calmer. Maybe that level of intention has decreased so that they can still stay safe. But even though we rate them at high risk because that's how it started. So what's high risk? That they have a plan, they have the means, they want to, and they say they're going to do it. Although they're not fully engaged with that. I mean, they're not fully going to do it because they've called us or they're talking to you. And as long as they have a meaningful engagement with you and with any of us, most of the time, they're safe in that moment. And what we want to do is keep them safe for longer, help them to stay safe for a little bit longer. So they've got the means, they've got the plan, they want to do it. So it's all 3, desire, capability, intent, in the moment. And we want to keep them safe. Now, how? If we get them to a calmer moment where that level of intention goes down, even if they say, okay, I won't do it now. I'm not sure, maybe later, maybe tomorrow, but at least not now. Well, then, so we're doing the usual, listening to them. Now, we do want to remove, we hopefully can lock up that gun or that rope or the knife, put it further away or go somewhere else. Listen for feelings of hope and a desire toward life. Ask team members one another, that's what we do at our place, Ask others for help. Develop a plan to stay safe for a specified amount of time. We're not talking about stay safe forever. It's safe for now. Let's just do this one incremental moment at a time. And we would certainly offer a follow-up call. Now, if it looks like they can't stay safe, or they say that they can't keep themselves safe and they want that help, we will initiate a rescue. The police would go, the ambulance, help them to get to the psychiatric emergency room, or maybe we would call the county's newly named A3, Mobile Crisis Response Team for mental health causes or incidents. All right, self-care is so important for all of us. It's 11:31. According to my computer, we have done it. Practice exercise, come back to another training, give us a call, book us at your place. I think I'm going to stop sharing now and be happy to entertain questions or comments.
There is a question, a few here. I know one of them is tips on how to assess or / engage with patient with major depression that is not willing to talk at all. Patient had attempted suicide before.
I think this is why I would say there are two levels of this. I mean, obviously there's depression going on, major depression, they're not talking. I mean, that is, and if we're talking about someone in the medical field and they've got someone in front of them, or, I mean, you said patient, I mean, then, are they safe? I mean, I suppose as a doctor would have to say, are they safe for now? Are they safe enough to discharge, let's say, from the emergency room? Obviously, that's a difficult decision and regrettable when later on there's a subsequent death by suicide. But so someone isn't engaging. It would be to do our best to, well, first of all, to engage, if at all possible. And that, I mean, so that's the skills of the counseling skills, I guess. And sometimes it takes time, and that's the challenge. Sometimes it takes time for us on the call, and it requires the counseling skills of the listening and the empathy and engaging with that person. So that's challenging when you have a limited amount of time, and depending upon what the context is. Now, but the next issue is to try to get a sense of what is their level of risk. What do you know to be true? Now, and then it's a matter of how you interact with that person, or how you end the engagement, how you end the call. I mean, let's say like we get calls, and maybe it's easier for us, but we get calls, and maybe even someone says that they have thoughts of suicide, and the conversation goes on, and then for some reason the call ends, but they didn't tell us, and for some reason the call ends, maybe prematurely, so to speak, and that we didn't get to ask all those questions. We don't really know the answers. Do they have a plan? Do they have the means? What's their level of intention? All we know is whatever their story that they told us in the brief interaction. Now, for us, it's easier that we can trust and hope and let that caller go. So, and I don't mean go to death. What I mean is that we will respect the autonomy of that caller, in that the caller didn't give us indications. Now, I mean, they said they had thoughts of suicide, and then maybe the conversation goes on and we don't have any more information. So we don't know if they're at moderate or high risk. They ended the call. Well, we hope for the best and hope that they had a sufficiently positive interaction that they would feel free to call again. I don't know if that's a suitable answer for the context. It's different for different contexts, how one responds to those kinds of concerns.
Another question says, does the Crisis Center help connect people to ongoing mental health services?
Absolutely. Absolutely. I mean, so what we would do is suggest, propose that, ask, gee, do you think that would be helpful? Have you been in counseling before, or have you thought about it? Do you think that's something that might be helpful? And we would refer to the mental health access line. Depend if, if they have that insurance or no insurance, or we would ask, gee, do you have health insurance and do you want to connect with your own doctor and get a referral? So absolutely, yes. We do not want to, we're a crisis line and we do not want to build our own ongoing clientele. That's not our purpose. We are in the moment. Now, some people do call us often or frequently or for a while, but we know that we don't do therapy. We are in the moment. And that's our training, is to train you all, I guess, of course, I don't know exactly who you all are, but to be in the moment, help them and get them to what can help them on an ongoing basis.
Okay, and then another one that I see on here says tips for patients with SUD as well. Thanks.
I'm sorry, tips for patients with
SUD?
SUD, substance use disorder. Ah, well, I would say this, that a tip, since you asked for tips, whoever you are, is it is so important to be patient and kind and non-judgmental. And maybe we all know that, maybe that's our goal, and maybe it's hard. I got a call the other day from a young person who felt very ashamed of her marijuana use and felt, but she's calling us, and she felt, and she acknowledged that she recognized that she herself named that her marijuana use was getting in the way for her and her goals. And she even said at the beginning of the call, it was her first time calling the 988 line. She says, "Are you all non-judgmental?" And I said, "Well, that's our goal." Now, and then I let her know that, to seek assistance, or even I let her know about Marijuana Anonymous. And she thought, oh, that's nice. Other people who have that issue and wish to be supportive to one another. Who knew? She didn't know about it. So what? I mean, if they are under the influence of something in the moment, well, then we got to really do our best to keep them safe. If it's an ongoing, and certainly I've heard from numerous people who have had substance use issues, that they have struggled with thoughts of suicide and or attempts of suicide, and that's part of the challenge of their lives, or had been, including, or maybe the substance use grew out of that concern. Obviously, numerous people turn to the substances as their own self-medicating. So it's worth looking at, to try to look at what else is going on in their lives and help keep them safe for the moment and get them to further help. And that's hard. Do they have insurance, or do we send them to what we call the AOD line, Alcohol and Other Drug Services line of Contra Costa, to get them to connected? I don't know, did I answer the question?
Okay, I don't see any more questions, Scott. I'm not sure if anyone wants to unmute themselves and ask an additional question. This is the time. And if there's no more questions, I know I had added a few announcements to the chat of the events happening at the Family Justice Center in the East, as well as we encourage you all to send in your request for training topics for the following year, as the list is already being worked on. I included my email, but I definitely want to take this time to really thank Scott for presenting today on such an important topic. So much useful information that we all need in order to better serve our clients in the same community and other communities. But definitely want to thank you, Scott, for your time and your knowledge, and everyone else that really put their time to be here and continue with the work that we do. And once again, this presentation will be sent to everyone. Expect it, give it a little bit of time, and you guys should receive it. Thank you so much, and enjoy the rest of your days, and happy Friday.
All right. Thank you very much.